And Dean, tell us about your department and your part of the operation as the lead physical therapist.
Yes, we have 8 treating therapists on staff, and we see a host of patients. A good many of them are referred from our doctors right across the hallway and from Dr. Sebastianelli's group, but we also see patients in the community, and we see a variety of diagnoses from cervical spine problems, lumbar spine problems, overuse situations, as well as acute injuries. And we have, I think, a very experienced staff. We're very, very lucky.
Give me your top 3 list. Tell me of the kinds of physical therapy that you're confronted with. What are, let's say, the 3 most common kinds of things that you're working on a day-to-day basis?
Well, I would say we see post-operative patients, and I'm not ranking these in any order, but post-operative patients that have had various problems, whether from an acute injury or trauma or an overuse situation. So we do see that population. We see, I would classify another group of individuals as cervical and lumbar patients, people who have various situations that result maybe from habitual posturing and positioning in their activities of daily life. And then beyond that, I think we see a lot of different athletic injuries in our clinic, from the weekend warrior to the high school athlete. We see those individuals as well.
Dr. Sebastianelli, what are the most common parts of the body that you are confronted with when there's an athletic-related injury?
Usually you could sum it up in 3 major joints, knee, ankle, and shoulder, and that will vary depending on what sport one's dealing with. Obviously in the throwing sports we'll see much more problem with rotator cuff or ligamentous injuries to the shoulder. But in most sports, the knee and ankle are very important, so they're commonly injured in any sport.
Now, our telephone number is 1-800-543-8242. I know there's going to be a lot of interest in our topic tonight, so get in the queue early. We're going to start with Scott, who's calling from Elk County. Good evening, Scott. You're on the air.
Hello. How are you guys tonight?
Real good.
Very good.
Fine,
Thank you.
thanks.
Okay, my question is, well, I was a high school athlete, and 25 years ago, I tore my meniscus, and I never caught it. So I'm bone on bone in my left knee. And they're telling me I'm too young for a knee replacement. Is there anything that I can do to help this?
Dr. Sebastianelli, can you be too young for a knee replacement?
Absolutely. It's knee replacement surgery should really be limited to individuals who've exhausted all sorts of medical management, and that includes the use of nonsteroidal anti-inflammatory medications. Orthotics are commonly forgotten about in order to help unload the knee joint. Appropriate biomechanical forces can be redistributed to help assist the area of your joint where you're losing your cartilage. Sometimes unloading braces can be developed, and ultimately in a young patient you can consider doing what's called an osteotomy, or a corrective fracture in your bone that will help realign some of the biomechanical forces. 25 years is pretty common after loss of a meniscus, either through surgery or just through dysfunction from injury.
Now, Scott, I assume that you've gotten some advice on this already, and have they given you some therapy to do or some exercises, or have they tried out any of these intermediate solutions?
They haven't tried anything. They wanted to transfer the weight from the inside of my leg to the outside. That's all they wanted to do.
Is this a kind of a problem that's amenable to some assistance through physical therapy?
Absolutely. Therapy can help redistribute some of the energy through your knee by creating a better endurance system to the extremity. So if you look at your muscles as a shock absorber, if they fatigue easily, then you're going to bottom out your frame, which is your bone, and you already have no cartilage in that one area. So flexibility and strength training are very important, and that's where Dean Plafcan's group would come in.
Okay, Dean, let's turn it to you then. You get a case like this referred from Dr. Sebastianelli with a meniscus knee problem. What do you work on?
Well, the basic things to do are try to keep the knee in balance and look at flexibility issues, look at strength issues, and then also try to determine where the pain might be coming from, because in my experience, sometimes these patients come in with a diagnosis of osteoarthritis, but we do, let's say, soft tissue treatment to the musculature, the muscles around the knee, and we really get oftentimes a favorable response. Not always, but many times the patient will have greater comfort with their activities of daily life by performing some of the flexibility things or the soft tissue massage techniques that we might do.
Scott, thanks for your call. Let's turn now to Sue, who's calling from Dubois. Hi, Sue.
Hi.
Hello.
My question is, I have a daughter who right now is 18, and she has a floating patella. They've done physical therapy on her, and they'll do that for maybe 2 months, and she seems to be doing fine, and then 2 years down the road, it acts up again. Is there anything else they could do besides the physical therapy, or is there some other physical therapy they could do?
Well, Dean, you must have this often where they come and see you for a while, they're better, and then you find out a couple of months later it's right back where it was. What advice do you have?
Well, I think in a situation where you have instability around the joint, whether be the knee with the patella or somewhere else, it really requires a lot of diligence on the patient's from the patient's standpoint to stay on top of these things. And I'm not real aware of what types of therapy this particular individual has had, but certainly I think there are maybe other things that can be done from a physical therapy standpoint. This may include some type of bracing, taping, or attempting possibly to modify the person's activity level, or trying to adjust what they're doing on a day in and day out basis.
Sue, I hope that's helpful, and I would say to you and any of our other viewers and listeners tonight that I know you folks are pretty heavily overloaded, but you're always open for new business, right, if someone would want to follow up on any of these issues that they're raising.
Absolutely, yes.
Great. Let's take a call from Fred now. Fred's calling from State College. Fred, what's your question tonight?
I have what I think is perhaps a silly injury, and that's that I went bowling about 6 months ago for the first time in 30 years. And ever since that night, I have a sore hip that I just can't shake. Mm-hmm. I've tried heat, I've tried ice, I've tried rest, I've tried stretching. What gives with such a seemingly harmless activity?
Well, I hope you got a good score at least. Okay. A bowling injury that has resulted in a sore hip. What do you think's going on there?
Well, we would have to be very specific about where the pain's located. And by hip, a lot of times it's, people will point to their SI joint, their sacroiliac joint, which is really more of a back injury. But if it's the hip joint proper, it's really going to be more towards your groin and will really hurt when you rotate your lower extremity. So just pointing your toe in and out with your knee straight as you're laying down on the floor will create pain if it's really coming from the hip joint. If it's really from the back, it'll be more midline and more towards the top of where your iliac crest is, that big, heavy, thick bone that is really part of your pelvis. If it's in the hip joint proper from bowling,
I think that's what it is. It's the former, as you described it. It's the groin area.
The groin area. Then one of the common things that can happen, how young are you?
Well, since it was 30 years ago, it gives you a pretty good idea. I'm over 60.
A lot of times you could have what's called a degenerative labral tear, which is basically the equivalent of the meniscus in the knee. So the hip joint has a rubber bumper system that helps create stability and cushioning, and by increasing depth to the joint, it creates stability. But you can actually tear that, and that can become almost like a little unstable fragment that could get caught inside your hip joint. Very tough diagnosis to make. Requires a lot of times the use of the MRI scan with some dye injected into your joint so that you get the appropriate look at the labrum.
Tell us about the relevance of MRI scans now. How often do you do those? And it seems to be getting pretty common for orthopedic surgeons to be doing MRI scans.
Yes, MRI scans are becoming much more sophisticated over the years, and the techniques are really dependent on the power of the magnet and the use of a surface coil. They can really diagnose articular cartilage problems, ligament problems, bone problems with blood supply issues. and are really very, very sensitive when the joint that's involved is filled up with some fluid, or at times you can actually inject some dye into a vein that will help create a sort of an internal painting of that joint that will create more detail to the joint itself.
Our next caller is Daniel, who's calling from Lewistown. You're on the air, Daniel.
Yes, sir. I'd like to ask Dr. Sebastianelli. Sir, I was in a terrible truck accident, and I had to learn how to walk all over again. 2 years ago, I had a meniscus replacement done on my right knee here in Lewistown. And ever since then, I mean, I really just can't walk on my knee, and I walk at least a mile a day, try to keep everything moving. I'm 45 years old. They told me that I'm too young to have a knee replacement. And I got like 40 different kinds of braces. I mean, I've tried everything you can think of, tons of physical therapy. Am I, in fact, too young for this? Or, if you have any ideas, I'll certainly try anything at this point because I have to keep moving.
How long ago was the replacement put in?
2 years ago.
And to the best of your knowledge, was it on the internal or the medial side or the outer side or the lateral side of your joint?
They took the whole meniscus out of my knee. Everything. It was ripped from side to side completely. I walked around for 3 years on it like that.
But they have not replaced anything?
No, they've just completely removed the meniscus tendon. And now what's happening is my kneecap is riding on my shin bone, and I have bone spurs all over it.
Well, I think one of the previous callers alluded to a similar problem in the sense of being very young and not really being a chronological candidate for a total knee replacement or even a partial knee replacement. But in your instance, several things to try would again be the use of arthritic medication, sometimes joint supplements like glucosamine sulfate and chondroitin sulfate are very helpful. There is a new one that's coming out from Europe called collagen hydrolysate that has some promise. There's unloading braces. There's, again, corrective fractures in the bone, which are called osteotomies. And then ultimately, you would really need to consider partial or total knee replacement. But again, at your age, I would try all of these issues first and really get into a good medical management program before you embarked on replacing your knee.
Thank you, doctor. I appreciate it.
You're welcome.
Good luck, Daniel.
Thank you, sir.
Next on the phone, we have Robert. Robert, tell us where you're calling from.
Carthage, Pennsylvania.
Okay, well, welcome to the program.
Yes, sir.
And tell us what's on your mind this evening.
I'm 68 years old, and about 6 years ago I had my right knee replaced, and 5 years ago I had my left knee replaced. And of course I thought that I was a young kid, and I went bowling over to Last Cowboy, and I couldn't get stopped. I let the ball go, and I fell down and right on the lane and hit my right knee on the center divider. And of course they got me off of the lane, and I kept right on bowling, but my leg kept hurting, and that knee has hurt ever since. And I went into Shannon Valley here a couple months ago, and they x-rayed it, and they told me that both of my knees are full of arthritis, which I got arthritis all through my body. I take Darvocet every day. I'm just wondering if there's anything else that I can do.
I had no idea bowling was so dangerous.
I didn't either.
Well, what ideas do you both have in a situation like this?
Why don't you start, Dean? Go ahead.
Okay, well, my thought is that I think you probably need to be evaluated by the orthopedic surgeon who did the surgery. I think you really need to get a diagnosis of what may have happened here.
Uh-huh.
And did you return to the individual that did the surgery?
No. The doctor that done Dr. Fugate, he was in Shannon Valley, and after he done my knee, he moved out and he went to up to Punxsutawney.
Yeah, well, I think it's absolutely crucial that you be evaluated by someone, another orthopedic surgeon. I think getting a differential diagnosis, a diagnosis of what you may have done when you fell, is absolutely crucial to resolving this issue.
I went into Dr. Nartatis at Shannon Valley, and he x-rayed both knees, and they showed up my picture. They had it right on the TV screen in there, and he said they look good. He said there's no scratches, no cracks or nothing. He said you just have in between your joint where it was a total knee replacement on both of them, and he said that they look good, but he said there's just full arthritis. And I don't know whether they can take them apart and take that arthritis out. I had arthroscope done on my left knee about 20 years ago, and it lasted about 10 years, and then finally I hobbled around till I finally they've done both of my knees, and I can get along now. But the only thing is now I'm in a problem. I have to walk with a cane. I have no balance. I don't know whether that's coming from my knees hurting or what.
Dr. Sebastianelli, further thoughts?
Well, I'm still a little bit unclear. Are there actually artificial parts in your knees now?
Oh yeah, yes. They're total knee.
Okay.
Total knee replacement in both of them.
And then with knee replacements, if there's continued pain, we would really need to get an assessment as to whether or not there's been a breakdown in the plastic liner, which is called high-density polyethylene, or whether or not the implant, which is metal, usually cemented into position. Sometimes the cement interface or the grout that actually holds that metal in position can get loose. And if that's happening, there's some special tests that could be done to help delineate that. And I would agree with my colleague, Dean Plafcan here, that you probably should have Dr. Nartatis take another look at that and see whether or not you qualify for additional studies.
Right.
Could I ask you both to...
that's what I'm going to do then.
Well, good. Thank you.
Thank you.
Thanks for your call. What about prevention? Now, we're talking to some people here who've had injuries and had problems and are trying to deal with them now, but can you throw out a few bits of advice to people about how to prevent some of these things from happening?
Sure. Go ahead, Dean.
Okay. Well, I would say first off that prevention is very specific to the individual and the activity that they're doing. But in general, off the top, you mentioned doing too much, too soon, too fast. I think things need to be graduated when you perform an exercise program. And I think you need to be aware of what specific things apply to the activity you're doing. If you're riding a bicycle, you should be wearing a helmet. So those types of things I think are very important. And then just the basics, getting adequate rest, keeping your body hydrated, and just trying to take care of yourself.
What about warming up? How important is warming up, and what do you recommend someone do during a warm-up?
Well, warming up is very important, and in fact, it's listed in the American College of Sports Medicine recommends a 5 to 10 minute warm-up. I think it is important. I think it will prepare the tissues, the body tissues, for the activity you're going to perform. What you should do to warm up should be, in my opinion, a sub-maximal effort, sub-maximal exercise that mimics the sport or activity that you're going to perform. I think that is the best way to warm up.
And tell us about stretching. How important is that, and what will that do for you?
Well, I think stretching is kind of a controversial topic in regard to prevention of injuries. There have been a number of studies that kind of refute that stretching before an activity will prevent an injury. With that said, there are also studies that seem to imply that stretching is important. If you look at the factors of what's going to develop, if someone's going to develop knee pain, what are the factors? Well, one of them is lack of strength in your quadriceps, one of them is your body weight, and the third one is tightness or restriction in your hamstrings. So I think stretching is important, and if I think it's prudent to do a stretching routine, it's probably best to do it after you're warmed up, after maybe you have a slight sweat going, because one of the factors that affects the effectiveness of stretching is temperature, and when the body temperature is elevated a bit, you can get more out of your stretching exercises.
Dr. Sebastianelli, I see you out there on the football field, right on the sidelines every Saturday, and at a lot of other sporting events. So let's be specific. What do you tell the team, our athletes, to do? Do you tell them they need to go through a stretching routine?
We highly endorse stretching. And just to reiterate some of what Dean has mentioned, I think essentially stretching has an elastic component and has a plastic component to it. And in order to get both to work, the muscle tendon unit has to be warm. And the only way to get it to a little bit above normal body temperature is to exercise. And usually after 5 or 6 minutes of running around or on a stationary bike, you could then go ahead and proceed with your stretching. And stretching should be done very diligently and at least 3 times a week in order to be effective. Muscle has memory and will tend to spring back to where it was before it was stretched unless it's repetitively challenged. And a stretching program is it's like brushing your teeth to prevent cavities. It has to be done continuously.
If you're just joining us, this is To the Best of My Knowledge on WPSX TV and WPSU FM. I'm Graham Spanier, president of Penn State, and our guests tonight are Dr. Wayne Sebastianelli, a surgeon at Penn State Orthopedics, and the director of Penn State's Center for Sports Medicine, and Dean Plafcan, the lead physical therapist at Penn State Orthopedics. If you have questions about a nagging sports injury or about how to avoid being injured in the first place, give us a call at 1-800-543-8242. And for those watching on the web, our email address is response@psu.edu. Now, we do have a few callers in the queue, but one of them is an anonymous caller who did not want his voice or precise location to be known. So let me read the question. On my son's first day of basketball practice, his coach had the team run 7 miles. Needless to say, the players had difficulty walking for days after that. First, what can players do to recover after that kind of workout? Second, is 7 miles a reasonable and appropriate first day of conditioning? Wouldn't it have been wiser to start with 2 miles and slowly add miles? And third, the boys were not given any breaks. Are breaks and fluids recommended when running distances? Who'd like to wander into that question?
I'll start.
Okay.
It clearly is something that really needs to be reevaluated. An exercise prescription really should be detailed to the point of looking at the overall conditioning of the participant, what type of body habitus they have, what type of flexibility and strength do they have, and what type of skill set do they have. Not everyone can be a long-distance runner. If you threw me out there to run 7 miles, I would fail miserably. I just don't have that body type. Asked me to get in front of someone and run them over on a football field, I was pretty capable of at least competing. So I think you really need to identify what each athlete's body type is like, and perhaps even consider cross-training in some of the larger individuals versus the more speedy or more endurance type individuals. So I would fully agree that first-day conditioning of 7 miles is a little bit at this point exuberant, unless the kids have been participating in a preseason conditioning program. If they haven't been, then going 7 miles is a bit much. As far as recovery, that will take days, if not a week, to recover from something like that. There'd be significant muscle breakdown or rhabdomyolysis. You'll have elevated enzymes, lactic acid, creatinine. You will have delayed onset muscle soreness. The model usually peaks at anywhere from 48 to 72 hours. And depending on what type of mechanical alignment the individuals have, they could have significant stress reactions in a lot of the little ligaments in their feet and the tendons around their ankle. So icing would be important, maintenance of stretching would be important, and fluid rehydration issues and carbohydrate reloading would be important.
Let's take a few more calls, then I'm going to come back with some questions of my own. Let's turn now to Jim, who's calling from West Decatur. Hi, Jim. Thanks for being patient waiting on the line.
Yeah, hi.
Hi.
I got a piriformis problem. I damaged the piriformis muscle. It sits on top of the sciatic nerve, and then in the process of doing that, my SI joint goes out. It also, whenever I hit a hunk of steel, and it just, my biggest problem is my SI joint. Like when it goes out, I have a lot of pain. And I just wonder, I've talked to the doctor about getting it fused, but he don't recommend that because he said it cuts down on the radius of your bends and things like that. But as what I'm concerned about is there something I could wear or use to keep that thing from going out?
Mm-hmm. Before you jump into an answer on that question, Dr. Sebastianelli, explain to our listeners and viewers what some of the terms are that he's referring to and where these places are in the body.
Sure. The piriformis muscle is a very deep muscle on the back portion of your hip joint. It attaches from your sacrum to the actual piriformis fossa, or a little notch on the top part of your femur bone, which is your upper thigh bone near the hip joint. And that muscle is very intimately associated with the joint capsule of your hip joint on the backside, as well as a major nerve that runs down through from your back into your buttocks and down your leg, called a sciatic nerve. So sometimes piriformis injury may be related to not only the blunt trauma that you described, but also potentially some disc problems in your lower lumbar spine. And all of that,
I don't have that.
all of that combined could lead to extra stress applied to the SI joint. So if it's been evaluated and you don't have disc disease, then you're really dealing with a potentially a very fibrotic piriformis muscle, which usually responds to some physical therapy maneuvers.
Okay. Dean?
I had the physical therapy, but it just didn't work. And I've tried. I keep trying. This has been going on for 10 years, and I've tried everything, and I push myself, and I'm good for about 4.5 hours, and down I go. And when the SI joint goes out, then I am down. I mean, I have to go to a chiropractor, get it put in, and
Dean, can you suggest some things here?
Well, have you tried a sacroiliac belt for stabilizing that joint?
I don't know what that is.
Okay, well, it's basically a belt that kind of goes around your hip. You try to align it with the sacroiliac joint, on each side bilaterally, and you could wear that, especially when you're doing activities where you're going to be bending or lifting or those types of things that you described when, quote unquote, it goes out. That's something that, you've said you've done physical therapy, so that's the one thing that I would probably add above and beyond of, what you've mentioned.
Where can I get that belt?
Well, most, I guess what I would recommend is I would see a, health professional, physical therapist, or a physician. And most medical supply companies, if not most, many, do offer that or have that. You could seek that out.
Mm-hmm.
Okay, thank you.
Denny from Somerville, you're on the air. Thanks for giving us a call tonight.
Yeah, on my leg, I had my ankle joint broken. They took and fused it, put some pins in it, and anyways, about a year later, I'm starting to develop this like a big bubble on the side of my knee, and they can't figure out what that is. And I've been to several different doctors and everything, and nobody has an answer. They kind of thought it was a blood clot, and then they kind of thought they rolled that out, and then they thought it was like a Baker's cyst. They said it's not a Baker's cyst, so everybody just kind of stumped.
So your immediate concern is the knee.
Yeah.
But do you have any reason to believe they're connected in some way, or not?
Well, I don't know whether there's fluid in. They don't know whether there's fluid in it, or what I could tell them what to do or anything.
Mm-hmm. Dr. Sebastianelli?
Let me ask you a few questions. Is it the swelling located on the little toe side of your knee or the big toe side of your knee?
It's on my right hand leg. It's right up on. It's on the inside part of my leg, and it's right above my knee. And it swells up and it'll kind of twist my leg, the bottom part of my leg sideways.
And it's on the same side as your ankle fusion.
Right.
Okay. Do you feel like your gait pattern is different since your ankle's been fused? Do you walk with more of a limp, or
yeah?
Do you wear any kind of special shoe?
Yeah. For my right leg, they had to put like an inch onto the sole.
Okay.
Had an inch to the sole.
All right.
So I went and walked with a limp. And the shoes have the roller bottom on them.
So it has a rocker bottom sole, so you can push off.
Right.
Okay. Now, what does the swelling change in size quickly, or does it stay pretty constant?
It stays pretty constant.
And is it firm, or is it?
Kind of like jelly. Like it looks, like if I lay on my side and have that up in the air, it looks like just like a big jelly ball.
Well, I mean, there's several things it could be. One is that it could be a bursa in and around, which is a very thin sac normally that has just a trace amount of fluid in it. But as it gets irritated, it can become very swollen and engorged, almost like a sponge sitting in a bucket of water, and just keeps swelling and imbibing fluid. And that could be in and around your hamstring tendons. There's 3 tendons that come up and around that area that you're describing on your knee. The second thing it could be is a cyst actually in the meniscus itself, called a parameniscal cyst, which can become actually quite large and quite firm. Have you had any diagnostic tests done, like X-rays or MRI scan?
Yeah. And then everything's come back negative.
I probably would consider repeating those if they came originally back negative, because if you have actual physical evidence on your exam, then there should be some indication on an MRI scan that would show some abnormality. So I probably would suggest and recommend that you get that reevaluated again.
Okay.
Thank
you.
Thanks for your call, Denny. And next we have Lee calling from Clarion. Hi, Lee.
How you doing?
Good.
In '98, I was diagnosed with reflex sympathetic dystrophy, and it originally started in my left hand and wrist, spread up my arm, across my upper chest and back at about lower breast line, and down to my right arm and into my hand. I'm 5'10", 180 pounds. I've lost about 10 inches off my biceps. My chest is flat now, and I've lost, just quite a bit of muscle. And I was wondering if there's any exercise that would, at least try to help me keep the muscle I got. And is there any chance that I might be able to regain some muscle?
Dean, I know you've seen just about everything. Is what he describes something that you see quite a bit of? And what advice would you have for him?
Well, we do see that in our clinic, certainly. And it is, to be quite honest, a very difficult diagnosis to deal with. What I would recommend, and what I recommend to patients with whom I'm working, is that we attempt to do very low-level exercise to see if they can tolerate it, and then from there we try to build on that with a gradual progression of the exercise routine. In addition to that, I think attempting to find ways to modify the pain. Sir, I don't know how much pain you're in currently.
Well, right now I take 80 milligrams of OxyContin 3 times a day for pain maintenance. Then I take 20 milligrams of oxycodone for breakthrough pain.
Yeah. Well, and then beyond that, I think in regard to the exercise routine, you'd have to be very careful that you don't increase your pain condition with the exercise routine.
Okay. One thing I was wondering, though, for the muscle that I've lost, is there any chance of getting any of that back?
Well, I think there's always a possibility of getting the muscle back. I mean, a muscle will respond. There's a principle called the SAID principle, and basically that means that the body will adapt specifically to imposed demands. And the big question, I think, for you, to be quite honest, is will you be able to do enough muscular effort and be able to tolerate that to stimulate the muscle to adapt and kind of hypertrophy or enlarge in size.
I understand there. I'm pretty sedentary as it is.
Yeah, and it certainly would, as I said, would have to be very low level to see if you could in fact tolerate that and not, increase the amounts of pain and get yourself into a cycle of increased pain and more wasting.
Good.
Okay.
Good.
Thank you very much.
Good luck, Lee.
Thank you.
Next on our line is Sheila calling from Everett. And Sheila, before you ask your question, we've had mostly men calling. In your practice, do you see a lot more men or not?
No, I think it's pretty well 50-50 split.
I would add that I see certain diagnoses that are a little more frequent. We had a little more frequent, and we had a caller call about sacroiliac joint dysfunction, and I certainly see that much more in
So
young women.
we have a skewed sample of men just being a little bolder and calling tonight. But Sheila, we are delighted that you called, and let's get you on the air right away.
Hello.
Yeah,
Okay.
Go ahead.
What I was calling, I know you talked earlier about it, and I missed part of it, but my kneecaps are off to the side, and I had talked to 2 orthopedics, which had 2 different opinions. One felt that I should have a total knee replacement when I got older, which I'm in my early 40s, and the other one felt that I should go the arthroscopic route and try to get things cleaned out in there. My concern is which one is the best, and I get to the point where I can't walk on it every so often, and I need to walk.
Dr. Sebastianelli.
Yes. And how young are you again?
I'm in my mid-40s, 45.
Mid-40s. And have you've embarked on any particular strengthening program or biomechanical program, including orthotics and potential bracing?
I have a Palumbo brace that I wear. They told me to wear that when it was severe, and they gave me, took Tylenol and Advil, and pretty much try to keep the legs as muscular as, keep them moving as much as I can, but they didn't give me a definite exercise to do.
And have you actually had your kneecaps ever dislocate?
No.
Okay, so it's basically just been chronically tilted and sort of positioned out towards the outer half of your knee joint?
Yes, they tell me that my left knee is off to the side, as it's bone on bone, but the other one is not as severe.
Well, if the remaining parts of your joint are good, the joint, you can think of it as being 3 compartments: the patellofemoral compartment, then the medial compartment where the femur and tibia come together, and then the lateral compartment where the femur and tibia come together. If the 2 major compartments of the femur and the tibia are in good condition, there are some realignment operations that can be done, some of which would include arthroscopic techniques, but in your particular instance, if you're bone on bone, you may need to consider what's called a tubercle osteotomy, where you elevate the actual patellar tendon attachment to your tibia or the front part of your shin bone, and that will help not only realign or reposition your kneecap, but will also elevate it so that it's away from the femur bone where it articulates or comes together with the kneecap, and that can actually decrease your pain substantially. Without seeing x-rays and stuff, it's hard to say that you're a good candidate for that, but you probably ought to consider getting another opinion with that individual that recommended the arthroscopy and ask them if you are a candidate for that osteotomy procedure.
Okay. Thank you very much.
Thanks for your call, Sheila. Let's turn now to Kevin, who's calling from State College. I'm trying to get as many calls in as I can tonight. Kevin, you're on the air.
Hey, how you doing there?
All right.
Good.
Dr. Wayne and Dean, how you doing?
Good.
Doing good.
Yeah, I got a question about my son. He's very active down there at State College, and he has some pain in his right knee, and he saw his physical trainer, and he said that it could be Osgood Slaughters, and I was curious if you could just describe to me what that is, and if there's anything we can do to get better.
Sure. Osgood Slaughters is an overuse condition of the attachment of the patellar tendon to the front part of your shin called the tibial tuberosity. And what happens is that as the stress is applied to the bone, it would actually create microscopic injury to its attachment. And as we are growing, there's some actual cartilage there that will help that tuberosity also enlarge as your shin bone enlarges. And over time, you can create a free fragment of bone that will sit inside the tendon, and at times will become very mobile based on falling or stress, and will become very tender because it becomes inflamed in and around it. There's a lot of exercises that can be tried. There's a lot of taping techniques that I'll let Dean get into that could be tried, and sometimes just some anti-inflammatory medication and ice would be a good start.
Dean, your advice for Kevin?
Well, the one thing I would say that when I deal with people, I often break it down into kind of a little mathematical equation, and
Yeah.
I often tell them 1 + 1 + 1 will equal getting better. And one of the things that I find with Osgood slaughters is that rest is part of the equation, not to completely eliminate activity, but certainly to try to avoid those things and try to modify some things that seem to be increasing the individual's pain or exacerbating their pain condition. So that's what I would add beyond that. Certainly the basics of keeping the joint in balance with hamstring work and for flexibility and general strength and balance around the joint, I think, is important as well.
Thanks very much. Jeff from Bellefonte, you're next.
How are you guys?
Hi,
Good.
Jeff.
Hi.
I'm 31 now. When I was in 9th grade in high school in wrestling, I suffered an injury to my right arm. I was thrown to the mat, and I tried to brace myself with my right arm with my wrist. And I didn't damage the wrist, but what I was told was I broke the synovial fluid, or the sac that contains the synovial fluid in my right elbow. And I also damaged the ulnar nerve a little bit. Ever since then, every time I move my elbow, I can feel something moving around in there. And I was wondering, did I completely destroy the lubrication in my elbow? And what types of problems will this cause me to have in the future? And what can I do to head off any problems?
Let me ask you a few questions.
Sure.
Do you get numbness and tingling in your little finger or your ring finger?
I did when it first happened. That was a long time ago, and that hasn't happened in years. But after it first occurred, that did happen, yes.
And if you straighten both your elbows out, does one sort of curve to the outside more than the other, or they both look the same?
I think my right elbow curves out a little bit more.
And with respect to range of motion, is your involved elbow stiffer, or does it have the same kind of movement?
No, it has the same kind of movement, but I'm still active and I still exercise.
Mm-hmm.
And when I lift weights, I think because of the repetitive motion of, bending my elbow and straightening it out, it will start to hurt sometimes.
And has it been x-rayed recently?
No. Like I said, this happened when I was in 9th grade in high school. I'm 31 now. It hasn't been x-rayed since it occurred.
Well, the differential diagnosis for what you're describing could be several things, one of which would just be a simple bursa with a fibrous cord in it that could basically snap and feel like there's something moving around. But we would also have you probably should be evaluated and have an x-ray taken to make sure there's no related growth disturbance in your elbow, because in 9th grade you were still at an age where there's some growth potential left in and around some of your bones around the elbow. So it's possible you could have an injury there or an injury to the ulnar collateral ligament, which is the big ligament on the inside part of your elbow. All of those things need to be entertained, including the nerve dysfunction. So I would suggest you're 31, you're healthy, you're active. Be preventive and go out and get yourself evaluated by your family doctor. And if he thinks you need to see an orthopedic surgeon, move to the next level.
Okay, very good.
Thanks
Thanks
for your call, Jeff. Really appreciate it. When people are ready to start up a new exercise program, you constantly hear the advice, go and get a medical checkup. Now, I must admit that's always seemed a little lame to me. If I was going to start an exercise program, I just gradually start getting into it. Is that really very important? I mean, is that advice people should take seriously and literally go see your doctor before you start exercising?
I believe that it's very important once you start to get over the age of 45. Prior to age 45, it's not so critical. Mm-hmm. And other things that will go into assessing whether or not it's critical is what family history is involved, and whether or not there's been hypertension, any form of cardiac disease or cerebral vascular disease in the form of strokes. It's 45 in men, roughly 55 in women. And it depends on what type of exercise you're planning to do. Are you going to be a low-intensity exerciser, or are you really training to become someone who's going to be highly involved in competition? So the exercise prescription needs to be tailored to goals, body type, and family history. And anybody who's starting cold turkey really should, if they're over the age of 45 and a male, should be evaluated by a physician, and if they're 55 and they're female, should be evaluated by a physician.
Okay. Dean, I've heard the word RICE, the letters RICE for treatment of minor injuries. rest, ice, compression, elevation. Good advice?
Yes.
Would you add anything to the list?
I think in general that's true. I would explain the R of that, the rest. What that really stands for is a kind of a protective mode. When you have an acute injury, you have swelling and inflammation, and at that point you want to allow the injury time to calm down, and that would be, as I said, in the acute situation. I think that's good advice. The one thing I would add is that sometimes with ice we can have some strange things happen around the elbow, the ulnar nerve, around the lateral aspect of the knee, the peroneal nerve. You can have ice injuries to those areas. And some people have allergies to ice, so they need to be aware of that. And I always ask my patients that before I put ice on them.
Why don't you comment on the gels versus frozen water?
A lot of the gel packs don't, in my opinion, sufficiently cool the joint and get the depth of penetration that frozen water would. You always need to have a layer between the ice and your skin so that the skin is protected. The layer could be an ice bag, a plastic bag, but certainly you need to have a layer. And then there's also the risk of chemical irritation with if the gel pack were somehow damaged and it leaked against the skin.
The other thing, too, as well, is that a gel pack that is applied directly to unprotected skin can actually create a thermal injury or a frostbite, which could lead to blistering and potentially even full-thickness skin loss. So if the gel pack's not used appropriately and someone lays it directly on their skin and they fall asleep, and an hour later they wake up and say, oh, geez, this is real cold, you may be in trouble. So we try to discourage the use of anything but frozen water, or we a lot of times will describe using a large bag of frozen peas, which conforms well to the joint, and then you can eat them when you're done.
We have just scratched the surface of all of the topics we could have covered. We have Nick, Deanna, Amy, Joe still in the queue, and lots of other people trying to get in. I bet there's 100,000 different questions out there. We will have to do this show again. I want to thank you so much for being with us on the program
thanks
tonight.
For having
Fascinating stuff. A quick reminder, tonight's program will be stored in an electronic archive that can be accessed through WPSU.org. This site also contains links to online resources for tonight's topic. Thanks to our guests, Dr. Wayne Sebastianelli, a surgeon at Penn State Orthopedics and the director of Penn State's Center for Sports Medicine, and Dean Plafcan, the lead physical therapist at Penn State Orthopedics. We hope you'll join us again on Tuesday, December 21st, for the next edition of To the Best of My Knowledge. Our topic, Internet Addiction. For all of us here at Penn State Public Broadcasting, I'm Graham Spanier. Thanks for joining us, and good night.
To the Best of My Knowledge is made possible in part by a grant from the Penn State Alumni Association, connecting the Penn State family to the university and to each other for more than 130 years. On the web at alumni.psu.edu.
A copy of the program you've just seen can be purchased through Penn State Media Sales at mediasales.psu.edu or by calling 800-770-2111.